This is chapter 14 in our revenue cycle. There will be 11 questions from this chapter on our test with a total of 25. Now, for this test, you will need some scratch paper and you'll use the calculator that's provided on the screen. These questions may require some critical thinking, so make sure you're reading and use your knowledge. Take your time whenever you're doing these to just make sure that you're answering the question that it's asking you. So a little bit about kind of a summary. Revenue cycle analysis is when we examine our health data with the intent to improve and contribute to capture, management, collection of patient services and reimbursement. You need to make sure that your team members stay up to date on compliance. In this chapter, we're going to look at 11 case studies, and those case studies are listed on page 285. And these highlight the most common revenue cycle areas that the data analyst examine in order to support revenue integrity. Facilities and doctors can use this to improve their operational efficiency, and it also is a great way to increase our identification of any risk. Now, one thing I do want to say first and foremost is, as coders, we need to make sure that we're using those coding guidelines and you're reading through them to ensure that you're assigning proper codes as principal or secondary as it's noted in those guidelines. So think back to our coding. Remember, we had some that said code first. We had some guidelines that said use this one as the secondary, use this one as the primary. So we need to make sure that we are following those guidelines. So if we were to see a trend of increase in codes, we want to make sure that what we do is look at that and check our code sequencing. Oh, went too far. All right, so let's go back and review, and a lot of this is kind of review from everything that we've done. So we're going to talk about CMI calculations. CMI is the most common focus area for healthcare analysis. It compares the overall complexity of the healthcare organization's patients with the complexity of the average of all hospitals. Remember, it's looking at our MSDRGs, our relative weights. It's looking at resources that are used. So over here on the right-hand side, it's kind of the steps that we do. We first calculate the weighted volume for each MSDRG. That's simply multiplying the MSDRG times the relative value to determine, remember that usually the highest value is the most revenue. We add up all the weighted values, and then we divide that by the total volume to get our CMI. So our CMI is the sum of those relative weights and then the number of volumes or the number of times that it occurred. You will have multiple rows. Remember, we calculate each row. That's why it says sum the weighted volumes. So we are going to calculate each of those rows. So the tables in the next few slides are in the book. This first one is table 14.1. It gives us the MSDRG elements. That is on page 286. We have our MSDRG. That's 405, 406, 407. We have the type, the description. Then we have the relative weight. And then we have the volume. Then you can see we've totaled them and got our total volumes. So if we look at that first 14.1 and we say which one of those MSDRGs has the highest reimbursement, which one would it be? Well, it's going to be the one that has the highest relative weight. So that would be our 405. Now, if I look at the volume, which one of those has the highest volume? The highest volume would be 407. So my first step is that I'm going to multiply my relative weight by my volume, and I get that table 14.2 down there, which is on page 287. Now, the weighted volume, you see it says it's calculated right here. This is simply multiplying 5.5419 times 15, and you're going to get that. 2.9297 times 55, and you get this. 2.2257 times 78, and you get this. Now, this is our total volumes. This is where we've added all of these numbers, 148, and our total weighted is right here. All we did was add these together. Our next slide, this is the last step of this calculation. This is where we come up with what our CMI is. We come up with CMI by taking 417.8666 and dividing it by 148. And when we do that, we get 2.8234. So the CMI for this case would be 2.8234. Here's all in one step. This is table 14.4. It's on page 287. So again, you can see we multiplied each one, totaled the volume, totaled these. We took 328.5165. We divided it by 135, and we got this. You do have a test question where you have to calculate CMI. So make sure that you understand how to do that. Now 14.5 is another example. This one is just showing you volume increases for the highest weighted MSDRG. So we took the same information, we just increased the volume. So you can see that when we increase the volume, what happens to our CMI? Our CMI goes up. This one is a volume increase for the lowest weighted MSDRG. So our CMI increases when our volume for the highest relative weight goes up. Increased relative weight equals increased CMI, as well as the increase in the volume. Now, we did learn about something when we covered this material the first time. We learned about the cost to charge. That's our total cost to charge. And in cases like this, we couldn't determine the profit simply because we don't have what the charge is. So with our case mix analysis, we're going to analyze the growth or decline of a facility's CMI, the beginning phase for assessing the quality of coding and billing for hospital acute inpatient encounters. You're going to compare facility CMI to that of the peers, state, and our nation. And some things we're going to look at is it steady? Does it increase steadily or drastically? Is there a sharp or sudden decline? You want to begin the analysis at the CMI level and then drill down to the MDC and or MSDRG level. And remember that those MDCs and the MSDRG comes from coding guidelines. So again, like I said earlier, we want to make sure that we're following those guidelines and selecting primary and secondary correctly. So our first case study that we have is on page 289. And this is a trend analysis. So in this case study, what they're doing is they are looking at revenue below budget and trending lower. So they're looking at the different types of cases. They started by analyzing CMIs over the last 4 years versus benchmarks. So you can see there on page 289, there's comparison of 3 facilities. So what the facility University Hospital did was they decided to connect and share and analyze against academic medical center and the community hospital. So you can kind of see where those are different there. Over on page 290, this figure demonstrates the CMI trend experienced by university is different than the two peers. Only University Hospital experienced a drop in 2020. The next step in the analysis is to divide the admissions for university into medical and surgical to determine if one of the subsets is causing the movement. So you can see what they've done is they've kind of done that shift. At the bottom of 290, that's a bar graph that illustrates there's that shift in 2019 to 2020. It's negative in surgical and positive in medical. The shift may seem minor, but it's important to understand the impact of the small CMI shifts because it can have a large impact on revenue. The next step in the analysis is to drill down to the MDC to see where the shift might be most pronounced. This bar graph follows segments the actual CMI shift, not the percentage, by the MDC. The width of the bar represents the relative value, so you can kind of see some of those are wider. Over on 291, MDC 8, that's our musculoskeletal and connective, is the most significant category when both shift and volume are combined. One cannot tell from the data alone what has caused this. However, by performing a thorough investigation, the issue can be identified, and there were several areas that they looked at: coding and billing areas, changes in that MSDRG assignment, equipment purchases, new or expanded services, acquiring new facilities, and changes in physician personnel. Regardless of the root cause, compliance with established rules must be verified. If it's coding, then we need to question that. If it's compliance, and so we need to follow up and make sure it's matching our compliance plan. Now next we have outpatient service mix index analysis. So CMI, remember, is only used for inpatient hospital admissions. They use MSDRGs. Service mix is hospital outpatient, and they use our APCs. So there on the side, we're going to determine the volume and relative weight for each APC. We're going to multiply the relative weight and volume for each to calculate the total weight for that APC. You add up the total volume, add up the total weight, and then you divide that by our volume. It's the same calculation that's used for CMI. We're just using APCs versus MSDRGs. And that's important to remember with service mix, is that it's hospital outpatient, and we're using APCs, not MSDRGs. So we have a case study 2 is our SIMI, and it's actually 291 to 292. So you can read through and you can see where they actually have done. This case study shows you step by steps. If you will look on page 292 in your textbook, the relative weight for the first row is 0.8617. There were 540 of those done. So when we multiply 0.8617 times 540, that should be 465.318. So it's just like the steps that we looked at for CMI. We're just using APCs. So remember that in our MSDRG relationships, we start off with that top level of our MDC, and then we break it down into the MSDRGs. We have the different levels. We have with the complication or comorbidity, and that's CCs, or we have with a major complication or comorbidity, that's an MCC. So inside each of those MSDRGs, there's anywhere from 2 to 3 choices that we can make. We can have one that doesn't have anything in it. So MSDRG family is a group of MSDRGs that have the same base set of principal diagnoses with or without operating room procedures. which are divided into levels to represent that severity of illness. The MSDRG relationships pose a revenue integrity concern. Medical record documentation is used to support the diagnosis code, and it may not always be clear or used appropriately by the coding professional. Again, right back to that principle in secondaries. MSDRG should be correct, it shouldn't be overreported, and it shouldn't be underreported. So audits are done to kind of compare those MSDRGs. There's table 14.7 on page 292, which shows you simple pneumonia and the difference in the relative weight. So if I have pneumonia without any CCs or MCCs, my weight is 0.6821, very low. Whereas if I have an MCC, which means that it's been coded correctly, assigned the correct MSDRG, it's over double, 1.3335. Because remember, those are showing us the resources that we used, and that's how we get paid for those sicker patients, because they use more resources. So we want to make sure that we closely monitor those. Audit the reports. It should be consistent. If you see an area, let's say you do a report, you come up with a chart and you see that the major error is an MCC, then what we need to do is do a focused review on that MCC, kind of like it talked about in that case study number 1, where we're determining why did that happen. So our next case study is page 293. University Hospital is investigating the relative frequency within the simple pneumonia MSDRG family. That was table 14.7 on the previous page. The data analyst used a stacked bar chart to compare university hospitals' reporting percentage for each MSDRG in the simple pneumonia family to both academic medical center and community hospital peers during the study period. University hospital percentage for 193, 48.92, is much higher than either peer group, and you can see that based on your information there. Since this is the highest weight number of MSDRGs, a medical record review is warranted to determine whether inaccurate coding practices, also referred to as upcoding, are the root cause of the reporting difference. Medical records assigned MSDRG 193 should be reviewed to determine whether the assignment of the MSDRG supported through documentation in the medical records. And again, we're going to look at compliance. So it says down there at the bottom, it says poor documentation identified during intensive medical records should be addressed with CDI management and medical staff. Anything that's an incorrect code should be with the coding manager, and then they will discuss that with their team. Next, we have Medicare reimbursement variation analysis. The Medicare Hospital Acute Inpatient Payment System provisions, when activated, impact the total reimbursement amount. The result is a reimbursement that is different from the expected MSDRG amount. So remember that Medicare sets that at the beginning of their year, and it stays the same throughout. Collaboration between financial analyst and coding professionals is required to solve reimbursement variation questions from the healthcare leadership. So our next case study is on page 294, and this is a Medicare reimbursement. So a financial analyst is charged with the examining of the Medicare payment variations for MSDRG 474. Last year, City Hospital performed 14 cases. Of the 14, 6 had a reimbursement amount different from the expected payment rate. the expected payment rate is $30,426.75. The financial analyst, I cannot say that word today, reviewed the cases and collaborated with the coding manager to determine the cause of the reimbursement. So you can see there it's got a spreadsheet, data service, how much they got, and then the variation. So they identified the policy that resulted in lower payments was a PAC transfer policy, which was discussed in Chapter 5. When the PACT transfer policy is activated, the facility receives a per diem payment instead of the full MSDRG reimbursement. So remember, that's where they're transferred for another facility. One facility gets a per diem and one facility gets the entire payment. Next, 4 cases where the reimbursement amount was higher than expected. They identified that for 2, an outlier add-on due to the high cost of treating patients with those account numbers. The last 2 cases were linked to one physician. After review, the financial analysis discovered that a new type of joint implant was used. So the coding manager confirmed that a new technology add-on payment was received. So you can see how they just kind of broke that down. And if this is a great area to be in because they're using all of these numbers and analyzing everything to try to determine information. This is a great area. So if you really just think, oh, I love doing this and looking at this, then you might want to look into going into data analysis. And if you don't like it, that's okay. You can keep doing what you're doing. So next we have site of service analysis, inpatient versus outpatient. Utilization review determines whether the medical care is necessary according to established guidelines. It's part of managed care's cost containment. We talked about this in Chapter 2. So it's kind of a two-way cycle. You have medical necessity, and then you make sure that they're doing it in the correct place. So sometimes if we see that medical necessity isn't being met, or it's an error that keeps popping up on our scrubbers or rack reviews, then we kind of want to look at, is it because of the documentation, is it because of the codes, or is it the software that does the admission screening? So we want to talk to utilization review. Because again, remember, utilization review is where we determine if medical necessity is being met. So site of service reviews are another name for ensuring that the appropriate setting was used for the patient care. Inside your code book for outpatient CPT, I believe there is a list of sites of service with codes. Those numbers go on the claim form. So we're going to examine our medical documentation to determine if the admission criteria was met or did it warrant an inpatient admission. If not, then the site of service should have been outpatient, and that could result in a reimbursement adjustment. Several MSDRGs are under site of service review by improper payment review entities such as MACs and RACs. So this is kind of a case of making sure that the documentation and admission criteria are understood by the physicians. So this case 5 is the site of service analysis, and this is one that's prone to a utilization review. This is just plain and simple, goes back to that. No site of service issues, then it could be that there was an MSDRG issue, which could take it back to the coder. So this one is going to focus on diabetes. It's on page 295. It goes over to 296. So the compliance investigators are examining the reporting rates for some DRGs that are related to diabetes. We're looking at 637. Now, MSDRG 637 is diabetes with an MCC. So university is at 0.30, academic is 0.29, and community is 0.3. So they do look similar. The examiners are going to still look more deeply and examine length of stay. So over on page 296, you can see that there is a bar chart that shows the length of stay. The majority of patients are staying 3 to 5 days. In the data, it's consistent with the national expected length of stay of 5 days. Investigators review encounters in the 1-day stay to verify that the admission criteria and medical necessity were met. It appears that this DRG is being reported appropriately. And do go back, I'm not going to read the whole case study to you, so do go back and look at the case studies. I'm just kind of going through and giving you a little bit of an understanding of what they're doing. Next, we have evaluation management facility coding in the emergency department. So this is our CPT codes that are EMs. Some of these are prospective reimbursement if we're at a doctor's office, but these can also be charges by the doctor at the ED. So it could be office or other, new patient, established patient. Remember with CPT, that's important that you know the difference between are they a new patient or are they an outpatient. We do use this for ED and also critical care. So these codes are based on HCPCS, CPT and HCPCS, and they work to drive those APC codes. Each facility is going to determine what hospital-specific criteria needs to be applied for the E&M level of service and the determination of the ED visit. Auditing is necessary to validate that. Table 14.8 on the top of page 297 shows you HCPCS CPT codes with the APC group, the APC relative weight, and then the APC payment that's been unadjusted. Just shows you some examples of those. So our next case study is an E&M level analysis on page 297 and 298. The distribution is compared across a medium-sized not-for-profit hospital, 2 peer facilities, and the nation. The data use a stacked bar chart to show E&M code distribution during the study. It shows that A and B reported codes 99284 and 99285 at a much higher rate than Hospital C in the nation. CMS has suggested that the ED APC distribution should follow somewhat of a bell curve. Clearly, A deviates far from this, even though A has a similar reporting pattern to B. Everybody knows what a bell shape is, where it goes up high and then comes back down. They talk about that a lot of times with grades in a classroom. The data analyst must further examine the trend for Hospital A, again using a stacked bar graph to display trend-in data for the past 4 years. The data shows that Hospital A reporting of higher level EMs has increased from 25% in year 1 to 80% in year 4. So this is where we need to do a medical record audit and look and see what codes are being assigned and what medical documentation support they are. Next, we have our physician coding analysis. Like facilities, physicians' practices use the E&M codes for visits. Now, physicians are not able to use practice-specific criteria to assign E&M codes like facilities are. Physicians follow strict E&M coding guidelines that are nationally recognized. Payers perform audits to ensure that the E&M code is compliant with established coding guidelines. And again, we have that bell-shaped curve is our concept for our comparative analysis. Now, page 298 lists several categories that are available for physicians' use when it comes to our E&M. So case step 7 is looking at distribution and analysis of our EM levels for physician practice. This would be for clinic visits, and this one I believe uses new patients. It's on page 299. So, yeah, new patient. SuperPayer monitors the E&M coding for all of the primary care physicians that treat their beneficiaries. The SuperPayer analysis team creates a bell-shaped curves as displayed in the figures below that follows Dr. Rapido's bar graph exhibits. Unfortunately, Dr. Q's bar graph shows a skew toward the higher level of visits. So that's the first one. You see how it's not that gradual increase and a gradual down? It is not a bell-shaped curve. So based on the E&M distribution for Dr. Q, SuperPayer may request medical records for an audit. As discussed in Chapter 13, Revenue Compliance, third-party payers perform audits to ensure that data reported on claims is in alignment with coding rules and regulations. So they're going to be looking at medical record documentation to make sure that they are assigning the correct HCPCS so that we can get that bell curve going. Next, we have our outpatient code editor review. This was from Chapter 13. OCE is a software program designed to process data for the outpatient prospective payment system, pricing, and edit claims. It's based on our coding and billing requirements. It is an ongoing analysis of OCE results, can improve a facility's revenue cycle. Resolving OCE edit issues increases the efficiency and accuracy of the revenue cycle because you get more clean claims. So let me give an example. If the OCE kept running and they kept giving us an edit that we were missing a HCPCS code, for example, remember that a HCPCS, a true HCPCS, would be on our CDM, our charge master. So we may need to run a data report on charges to see if there's an error with our CDM, and that'd be done by our CDM coordinator. So you kind of have to look at the errors. So 8 is an edit analysis for hospital outpatient. This is a root cause analysis, and it's looking to see why we're getting OCE edits that are being activated. So remember, OCE is before we submit the claim. So this is kind of like an in-house type of looking at the claim to make sure it's right. We're making sure before we send it. Community hospitals submitted 1 month of Medicare outpatient claims for auditing by the Medicare OCE. The data had 2,530 claims, 17,710 line items, and look at the charges, 5,457,513. The results are displayed in the table below. And so you can see the majority of those are CDM or coding. So during that audit, there were several edits to improve that revenue cycle. So they decided to look at 41 and 48 because it was the highest number. So on 41, invalid revenue code. So in this case, this is just like the scenario I said, check the CDM and make sure that there is a code that is there and it's the correct code. And you can read through those and you can kind of see what they found when they went and looked. There's that 48 requires a HCPCS. And it tells us in there that we need to run that and make sure that the CDM, because the CDM could be the one that's triggering those. So you can read through those results. Next, we have physician productivity analysis. RVUs. We learned about RVUs in Chapter 8. The work element of the resource-based relative value scale must be used to determine physician productivity. The work element is based on the time the physician spends providing a service and the intensity with which that time is spent. There's the work element RVUs. Remember, we have 4 aspects: mental effort and judgment, technical skills, physical effect, and then the psychological stress. All of those are part of the RVUs. So in this case, we're going to measure physicians' productivity. We're going to look at how those work elements are used to determine. So it starts on the bottom of 301. So Healthy Physician Clinic is a practice that has 4 doctors. Dr. Anderson works full-time. Dr. Burns and Cruz are 30 hours a week, and Dr. Dudley is 20. The practice manager set up a RVU goal of 2,000 per month for each physician full-time. She created a physician scoreboard to measure productivity of each of the physicians against the benchmark for this month. The scorecard is shown below. It's actually on page 302. So there's your goals, and then the FTE status for each one. And then we had a physician goal for each one because they're not working the same amounts of times. Then they looked at the number of encounters each doctor had, what was billed, and then per encounter. So the practice manager adjusted each. Dr. Anderson is expected to achieve the full 2,000 because they're full-time. And then the others were kind of decreased. The practice manager was surprised that Dr. Cruz did not meet her RVU goal. She has a full schedule as demonstrated by the fact that she has more encounters than anyone else. The average RVU for Dr. Cruz is significantly lower than any of the other clinicians. If she's going to continue to perform lower weighted encounters, then her volume must increase to meet the clinic benchmark. An alternate pathway would be for Dr. Cruz to work with leadership to have a lower physician goal assigned for her. So it could be that that doctor has more critical patients and it's taken longer to go through and process those. Next, we have clinical documentation integrity. Remember that our CDI is there to do concurrent and respective reviews of that medical record. We're trying to improve the quality of the documentation. So that CDI program includes engagement from professionals and clinicians. There are metrics that are used. We talked about in Chapter 12 several metrics that we use to manage that CDI program. So our case study number 10 is our CDI program. It looks at the relationship between the CDI query response rate and physician specialties. So on case 10, it starts on page 302 and goes to 304. Letha, the CDI director at Community Hospital, was concerned that the rate the physicians responded to queries varied widely by specialty. So she created a bar graph, and there it is at the top of 303. She interviewed physicians from 4 specialties. After interviewing in the pulmonary and cardiology, she found that the physicians felt as though the number of queries and types of questions asked were not perceived to be valuable. The clinicians in those departments were busy and considered the CDI queries to be a nuisance. Letha thought it was interesting that this type of feedback was primarily provided by those 2 departments. Physicians in the oncology provided feedback that they appreciated CDI and were conscientious about responding. Physicians in the OB indicated that they were busy and they also tried to respond. Letha decided to do an analysis to look at the relationship between the query rate in each department and the corresponding response rate. And she did a scatter plot to show the results. And there's that. The scatter plot depicted in the 5 figures compares the physician query rate and response for the 4. cardiology and pulmonology have a lower query rate and a higher response rate compared to the others. The OB query is in the middle, and so is the response. Cancer has the best response rate, and this is not a surprise considering the feedback from the doctors. There is, though, a negative relationship with cardiology and pulmonary. So she decided to have Dr. Shapiro speak with the physicians in an effort to get them on board with the CDI. She will prepare a presentation that highlights CMI, risk of mortality, and severity of illness statistics, which have drastically improved since CDI efforts were introduced into this specialty. Next, we have MSDRG denials. Now, we've seen a rise in this in the past years. A portion of the MSDRG denials are due to incorrect coding. Again, make sure principal and secondary are correct. Code first, all those conventions that you learned in 1400. An increasing percentage of denials are due to clinical validation denials. The payer indicates that there is insufficient clinical indicators present in the medical record documentation to support the targeted diagnosis. So it's no longer sufficient to just have the physician document it in the discharge. It should be sent in the progress notes. Nurses, ancillary, everybody should be charting about it to support that diagnosis. Case study 11 is an MSDRG. This is looking at how to identify supporting clinical indicators in the medical record. It's on page 304. So we have a patient that is admitted to City Hospital with acute systolic congestive heart failure exacerbation. The patient has chronic systolic CHF, a history of breast cancer, and his status post-2 coronary artery stent placements. On day 2 of the admission, the patient experiences acute respiratory failure. The MSDRG reported is 291. Heart failure and shock with MCC. The payer has downgraded the MSDRG to 293, changing the code for the respiratory failure to hypoxemia. The clinical denial specialist is charged with reviewing the admission to determine whether the patient had acute respiratory failure or hypoxia. City Hospital has established the following criteria for a formal diagnosis of acute respiratory failure, 2 of the 3, and PO2 less than 60, PCO2 greater than 50, signs and symptoms of acute respiratory distress. The clinical denial specialist starts with signs and symptoms. She identifies that the progress note from day 2 describes patient in respiratory distress with labored breathing, nostrils flaring. The patient is unable to speak. The clinical denial specialist feels that this documentation supports signs and symptoms. Next, she moves to the arterial blood gas lab results. The patient has a PO2 of 51. The lab result meets the criteria for acute respiratory failure. But the clinical denial specialist continues to review. She locates another progress note that indicates the patient was placed on BiPAP, which is a common treatment for acute respiratory failure. Further, she examines the MAR and notes that the patient was started on prednisone, which is another treatment for patients with acute respiratory failure. A progress note on date 3 states the patient's breathing easier but will continue on BiPAP for the remainder of the day and complete the course of steroids. The clinical denial specialist decides to appeal the denial. She believes that the documentation in the medical record is sufficient to support the diagnosis of acute respiratory failure as recorded by the attending physician in the discharge summary. She prepares her denial letter and includes copies of the documentation that supports the criteria for acute respiratory failure. So that is that one. Kind of interesting. All right. Lastly, we have our patient connection, page 305 and 306. So in chapter 1, Patient connection, we learned that Dr. King is Olivia's daughter's pediatrician. Dr. King works at City Pediatrician Groups. She is one of 4 pediatricians. Yvonne, the practice manager, tracks physician productivity monthly, similar to the physician productivity analysis included earlier in this chapter. Let's examine the physician productivity for the month of May. For the month of May for the City Pediatrician Group. So if we look in our textbook 305, it looks like most of the visits are for clinic visits. The only pediatrician that did not meet the productivity goal is the only pediatrician that didn't meet the productivity goal was Dr. Aguada. Dr. Torres and Dr. Perez just met the standard. Only Dr. King has a WRVU per encounter over 1. So if you see on Dr. Aguada in the parentheses, that means you're taken away. Yvonne wants to encourage the physicians to increase productivity, but she does not want to sacrifice quality or compromise revenue integrity. City Physician Group has a community rating of 5 stars primarily because patients appreciate the times the patients spend with the patient, the time the physicians spend with the patients. Additionally, their last internal audit showed a coding compliance of 97. What would you do if you were in Yvonne's position? Let's see. If it gives us any more info. So one of the things that you might want to do is talk to the doctor first of all and see what he thinks, and then you may also want to break down and see what is it that his primarily Hicks picks are that are being coded. All right, so that is chapter 14. Lots of reviews, lots of case studies. Do go back and read those case studies. Remember that there are 11 questions. We've covered them. They are some formulas. Make sure you have scratch paper. Make sure you use that computer and read what the question is asking of you when you look at them.